Moving to from pachychoroid spectrum to pachychoroid neovasculopathy, we are going to the proper age-related macular degeneration, and we are here to Dr. Unni to speak about algorithmic approach to diagnosing and prognosticating AMD.
Good afternoon, and thank you for the introduction. So we are going to look at three parts. That is how we develop an algorithmic approach for diagnosis, initiating treatment, evaluating prognosis also. So let's start with diagnosis. Sometimes, do we actually need other investigations to diagnose AMD? Sometimes we do not. It's very obvious when you have hemorrhages or drusen or other things like that. So, but at the point of diagnosis, there are other criteria we need to find, like what is the location, whether it is foveal, non-foveal, or foveal by extension. That will determine the visual acuity. So this is an algorithmic approach. When you see a lesion, is it going to affect, vision in the future? The type, is it a pre-RP lesion, a post-RP lesion, or is it extensive and mixed? What is the activity? Is it highly active? Is it overt, just about to break into action? Is it a smoldering disease that you've treated multiple times? Or is it totally inactive? Is it a variant of the typical CSR? Is it typical or AMD? Or is it a variant of AMD with all these polypoidal CNVMs and all these other conditions? And what is the duration? Is it a new disease? Is it a reactivation? Or is it a chronic disease? So all this will affect, at the time of diagnosis, will affect how the disease is going to go in the future. So let's look at the type. You have the RP disease, pre-RP, post-RP. So we'll just check. This is a typical example of a classic CNVM. Where you have a lacy pattern. In the late stages, there's a fuzzy margins, all that you can see. And a typical OCT picture where you see a fusiform lesion with SRF. You see the fusiform lesion there with the SRF adjacent to it. Another typically well-defined lesion in the early phases of the angiography, the lesion is well-defined. In the late phases, you see blurring or fuzziness of the margins. Again, this is a classic lesion with something else also. You see a small amount of SHRM in that. Again, a lesion where you see a change with SHRM on the top of it. This is a lesion where you don't exactly see anything happening in terms of a membrane, and it's a little bit of a vague angiography. And when you see the OCT, you see the lesion is underneath the RP, which makes it a type 1 or a pre-RP lesion or an occult CNVM, how it was called before. And sometimes you have changes in both the layers where you see you have a pre-RP lesion and then you have changes above the RP also. A type 3 CNVM is also called RAP, which has a retinal component to it also. So let's look. When you have a pre-RP lesion, you have, the chance for recurrent, a type 1 recurrent activity. When you have a post-RP lesion, this is the tendency to scar is there because it is above the RP, and you have a propensity to have a foveal involvement. When you have a PCV lesion, these are the two things that you're worried about: recurrent activity, and you're also worried about massive subretinal bleeds. When you have extensive, it is likely to be foveal in location, and you have extensive scarring along with it. So let's come to the second point. How do you initiate treatment? When do you initiate immediately? When it is a typical lesion and you have signs of activity. It's a very simple fact. When do you defer initiation of treatment? When you see nil activity, that is when you see something called a non-exudative CNVM. You see a CNVM, but it is not exuding SRF, or it is not exuding, it doesn't have a hemorrhage. So this is an example where you see a small elevation over there, and you see the small elevation happening here, and on the OCT angiography, you see a small vascular network. You can jump to call it a CNVM, but it is not a CNVM. It is a CNVM, but it is not an active CNVM because there is no SRF. Again, you see a small disturbance over here. You see a CNVM here, but there is no SRF. This is the component of a non-exudated CNVM. Again, these are other examples of non-exudative CNVMs. They can sometimes appear like a classic membrane, but they do not exude fluid. So let's get back to Another point where you defer initiation of treatment is when you see minimal activity. You're not sure of the activity. There is a component of something called non-neovascular SRF. That is, you see fluid, but there is no neovascular component. We'll show you some examples later. Again, this is an example where you see some elevations of the retina. You know that the PED is increasing in size, but you don't see SRF per se, or you see a small gap at the edge. And these are trains where sometimes you don't need to treat because of this thing. Non-neovascular SRF. When you see a large lesion and at the tip of the lesion or at the edge of the lesion you see fluid, or you see two PEDs and like a blanket covering it, there's a small gap in between. That is when you call it, it's called a drape sign, or all these things. And these are either fluid at the top, this may not be neovascular, or fluid between two PEDs, it may not be neovascular, or like a blanket not covering something properly, you see the edge of something over here. These are examples of SRF in the absence of neovascularization, and this is when you can observe and don't treat directly with the anti-VEGF. You can observe for a month or two and see if it changes. Another examples of the same thing over here, where you see fluid on the top, but this, what is the problem of treating this aggressively? If you treat this aggressively, you can end up with this. You can end up with RP atrophy. So it is an important component now to realize what fluid not to treat. These are similar examples of those. So if you have a doubtful diagnosis, that's also when you defer treatment. That is when you don't jump into treatment. One of the examples is adult vitelliform. You see elevations of the retina, you think it is SRF, but your autofluorescence reveals that there is autofluorescent material. Another example, you see a yellow spot, you see something like this. It's hyperfluorescing, and this is another example where this is called a torpedo maculopathy. It looks like this, and you see something that looks like fluid. This is not fluid, it's a change in contour of the choroid, and overlying it looks like fluid, but it's not exactly fluid. So once you start treatment, you're thinking about the next step, how to continue treatment, that is propagation. And therein which you have to describe what are the less aggressive features and the highly aggressive features. The less aggressive features are this particular feature. It's called multi-layering, where underneath the fibrovascular PED you see layers. Why is it called less aggressive? These do not bleed massively. The fluid does not go away, but they do not bleed and lead on to scarring very commonly. This is something called laminate bodies, where you see small specks underneath the PED. And both these, though, are difficult to treat and difficult to get rid of the fluid, there is a point of time where you will have to accept that I'm going to live with this much fluid. And this is the other features which is highly aggressive, extra large PEDs with fluid. The tendency to have a rip is very high in these. So this is the extra, high aggressive features. And another feature which is highly aggressive is the SHR, the subretinal hyperreflective material. Why is it aggressive? Because sometimes this SHRM leads on to form thick scars at the posterior pole of the fovea, which limit visual acuity improvement even after proper treatment of the AMD. Persistent fluid is something we have to know. What do you mean by persistent? There's no SRF is good, or there's nothing called beneficial fluid, but there is a concept now, you can tolerate some fluid, and that is 200 microns of fluid. You can tolerate 200 microns of subretinal fluid provided it does not change or the visual acuity does not drop. That is what you mean by persistent or tolerable SRF. When we go to maintenance of treatment, these are the two things. One, there's something called a reactive regime, or PRN. That is, you see the patient, if there's fluid, you treat it. And there's a proactive regimen, or the treat and extend, where you treat it even if you do not find fluid, and you increase the interval so that you maintain flatness of the retina. So the aim of AMD is not to treat the OCT, but to prevent, this is the main, to prevent long-term visual loss, which happens if you create RP atrophy, or if you do not treat well enough and you create large subretinal bleeds. Not you create, but God creates and you keep on watching. So you can either continue till nil activity, which requires aggressive monitoring, or less aggressive monitoring and looking at OCT biomarkers. Or you can also accept activity. Like we said, define stable SRF, which is the most important thing. Accept 200 microns of fluid if it doesn't increase. Or if you see changes like outer retinal tubulations. If you see them, you don't treat more aggressively. If you see multi-layering, you can decide that it's not that aggressive, and you can watch it provided fluid is not increasing. or by your treatment, if the RP atrophy, that is whether you're getting fluid going away or not going away, if you see that RP atrophy is increasing, you should be careful about over treating this patient. You may have a dry fovea, but you'll have RP atrophy and severe visual loss. So this is what I talked about, persistent fluid. You have to decide at what point of time, if the visual acuity is good, you will stop treating and keep observing. Outer degenerative edema and outer retinal tubulations are something that can tell you that it is an RP decompensation overlying the scar and not exactly regenerative SRF. When to stop, we've discussed, and when to restart. Any reappearance of a pigment epithelial detachment means the activity has come back. So any reappearance of a PED is indication to restart anti-VEGF again. And other signs are obviously like bleed or SRF, or other signs like appearance of a vitreomacular traction, which can restrict activity, is another sign. So this is what you mean by a reappearance of a PED. The patient was flat and suddenly there is a PED repairs, increases, and it increases in volume by being multi-septate. Evaluating prognosis depends on the location, depends on the nature of the disease, whether it's typical, it is a variant, whether it's RAP, worse prognosis, PCV can have worse prognosis, or a RIP. If you have, that's a type 3, if you have SHRM, whether it is persistent, if you have hyperreflectivity and it doesn't go away, that is an indication that this patient has a poor prognosis and is going bad. If you, so this is SHRM vascular, which persisted even after treatment and kept on becoming denser and denser till it became a scar. So persistent SHRM is an indication that the patient is under poor prognosis. Multi-layering, I told you, is not bad sometimes. A scar may be present with activity, where you have fluid, or degenerative changes where you have ORT. You have to differentiate so that you don't overtreat the patient. The background retina, whether there's already pre-existing geographic atrophy or the RP is increasing with each treatment, and other choroidal features like a thick choroid, or now even just the opposite, a thin choroid. A leptochoroid patients, if you treat aggressively, they go into RP atrophy very, very fast. And finally, this is an example of RP, what do you say, leptochoroid, where you say an extremely thin choroid, the patient after treatment has gone into RP atrophy over there and a poor visual acuity. So imaging has not only revolutionized the treatment, it's revolutionized our understanding, what to treat, how long to treat. But the most difficult question in any AMD or DME is not when to start treatment, it's when to stop treatment. And that is where we all fail most of the times. Thank you very much.
Thank you, Dr. Unni. You talked about preventing subretinal bleeds. Is it always possible to prevent a subretinal bleed despite us treating aggressively?
Yeah.
And does it mark any clinical prognosis? When you see a subretinal bleed, do you think of something else as well?
So it is very difficult to predict a subretinal bleed. Usually they don't happen when you treat it. They happen 2 times. One, when you are presented with an extra large PAD and you treat very aggressively, it can rip. The second, usually it's not like that. It's a disease where you think has come down, you think it is quiescent, and suddenly you extend the follow-up so much that you don't pick up any features in between. So when you have a disease like PCV and you flattened it, and then suddenly you say, I'll see you after 6 months. This is the most common scenario where they come back to you as a subretinal bleed. The other is not in your hands. When you're treating a PED, active PED, and it bleeds, it's not in your hands. But the second thing, so determining when you are going to see the patient again, what are you looking at? There are 2 things that you have to look at, which we don't look at. One thing could be the re-increase of the choroidal thickness. We hardly look at, if the retina is flat, we don't look at the choroid. You should look at the choroid to see if the choroid is becoming thick again. Point number 1. Point number 2, do you have diffuse RPE changes like DLS happening in the meantime? There may not be fluid, there may not be PEDs, but you can see the RPE disturbance in the form of larger things. And then that tells you something is happening under the choroid that causes changes in the RPE.
Thank you very much.